Good morning to all. This is Dr. Anupama Gotimukula, President of AAPI. And this is the month of November. And every month we have been doing CMEs for our members every second Saturday. And today is November 13th. And we are going to present the CME session, which is 2 hours of CME, which is accredited by the Chicago Medical Society. And today's topic will be on telemedicine perspectives, keeping up with the changes in healthcare. And I welcome you all, and I welcome Dr. Amit Chakravarti, our CME chair, to start the session. And here you go, Amit.
Yes, thank you so much, all of you, for attending. This is a slight deviation from the time which we usually start because of the speaker's previous engagement, and thank you very much for joining in. We have a very, very distinguished panel today, and like we have always said, this year's as a CMA chair, this year Anupama and I and the other members of the CME committee, we decided to do CMEs which are more generalized, like for every specialty. Let's try to keep away from specialty-specific CMEs and do generalized CME, which will be of interest to physicians of all specialties. So today we're going to talk about telemedicine, and we've got an exciting panel. So let me introduce the first moderator, Stella Gandhi. She is a board-certified internal medicine physician who actually has been practicing telemedicine full-time for the last 6 years. And I couldn't have thought about any better person to be a moderator for this session on telemedicine. She's a medical advisor and lead physician for 28 Health and provides virtual care for Oscar Health Insurance. She's a past YPS president for AAPI and served on the IT committee for the last 2 years, and currently the chair of the IT committee of AAPI. The second moderator is Dr. Amit Bakshi. She is also a very well-known figure in AAPI. She was the past president of the Young Physician sections of AAPI. She's a board-certified psychiatrist based in New York City and specializes in women's mental health and telehealth. And she's the medical director of ambulatory telepsychiatry for Northwell Health and director of ambulatory psychiatric services for Lenox Hills Hospital. So again, we have got an amazing person who is going to be a co-moderator on this session because they are very well versed in telemedicine themselves. She also enjoys teaching and mentoring trainees and is the director of medical education in her hospital. So the third and the first speaker of today's session, and I'm going to introduce her and let her speak, and then we'll have some question and answer sessions, and then we'll go to the second speaker, question and answer sessions, and then we'll have the last person who will sum up everything, and we'll introduce them as we go along. The names, the two speakers are Veronica Sikka and Manish Garg, and the person who is going to wrap everything up is Sagar Gallinkar. So, but let me first talk about Veronica. Veronica, who is the first speaker, is an emergency medicine trained and boarded physician who works as the chief of virtual care of VA Sunshine Healthcare Network, former chief of emergency department at Orlando VA, where she led the opening of the first ED in Central Florida to serve American veterans. She's very passionate about teaching medical students and is an associate professor of emergency medicine at UCF School of Medicine and teaches nationally emergency medicine. She has started a partnership with Orlando Regional Medical Emergency Center and does a bunch of things to get in a teaching facility. She's interested in taking complex medical topics and has worked with World News Tonight, Good Morning America, and she's kind of a celebrity in her own right. She's also very well published. She wrote a LWW book called Step Up to the Bedside for medical students preparing for the USMLE. She's widely published in both emergency medicine and healthcare leadership, and involved in the Orlando community, and volunteers at Shepherd's Hope, where she was recently named Associate Medical Director. In her spare time, Veronica and her husband, Raj, who's a gastroenterologist in the Orlando area, love to travel, go biking, work out, cook. They've got a daughter, Ravina, and son, Ravi, and they are doting parents to these lovely kids. So without further ado, and I'm Amit Chakrabarti. I'm the present CME chair and also a practicing urologist. Over to you, Veronica.
Thank you, Dr. Chakrabarti. I appreciate the introduction. And thank you all so much for the opportunity to present at the AAPI CME. As Dr. Chakrabarti mentioned, my name is Veronica Sika. I currently work with the Department of Veteran Affairs as their Chief of Virtual Care for the VA Sunshine Network, and we're over all of Georgia, Alabama, the VA Caribbean, and obviously Florida. I'm going to go ahead and share my screen if I may, and then go through the presentation. I've got two screens, so let me know. Can you see my screen?
Yes, we do.
You do? Okay, great. Thank you. So let's see if I put this in presentation mode, will it mess up anything? Does that still work? Okay. So my topic is telemedicine in the Department of Veteran Affairs and experience with the Visinate Clinical Contact Center. So what exactly is a clinical contact center? That is essentially a virtual urgent care. The Department of Veteran Affairs is very big on increasing access for our veterans. And obviously we can do that in person with primary care, mental health, specialty care. But what was lacking about 2 years ago was telemedicine. Telemedicine was kind of done on the periphery in the Department of Veteran Affairs, but it wasn't very formalized. As Dr. Chakrabarti mentioned, prior to joining this position, I was the chief of the emergency department at the Orlando VA. Just a little bit more background about myself. I had a change of life with two little kids. I have a 2 and a 4-year-old, almost 3-year-old and 4-year-old, and wanted a different change of pace as well as a new challenge. So I started the emergency department from the ground up at the Orlando VA, but wanted to now do something different, but something that would also allow me to stay at home with my little ones. And so this position came up, the chief of virtual care for the VISN. And so VISN 7 right now VISN 8 consists of North Florida, South Georgia, all of Florida, the Caribbean islands. We have instituted this clinical contact center for the last 2 years now. And because of our work, the president has mandated that the entire country, when it comes to the Department of Veteran Affairs, all have their own clinical contact centers. So we were the first. I always tell everyone when we're giving this presentation is we were the first doesn't mean we were the best. We're always open for suggestions. We're almost always open for feedback. But we were the first in the Department of Veteran Affairs world to develop a clinical contact center. And now the rest of the country is following suit in response to the president's mandate to have the contact centers throughout the country up by January 1st of 2022. So we're working very hard to obviously help others set up their clinical contact centers, but have also been asked to merge with VISN 7. So we are going to be collaborating. I don't want to say the word taking over, but we're also going to be collaborating with VISN 7 and providing care now to all of Georgia and Alabama, in addition to the current states that we cover. So in terms of disclosure, relative financial relationships, I have none. And then just the disclosure of off-label and or investigative uses, none. I want to give a special thanks to Dr. Sagar Golankar. He is my true mentor, and I always call him Bhaiya in every right, because he is really knows me since I was a medical student till today. So really thankful to him for his mentorship and leadership in the telemedicine and emergency world, not just nationally, but internationally, and the entire Indus research team. Also special thanks to AAPI for having me today to present on this topic, and my colleague, Dr. Manish Garg. It's an honor for me to be presenting alongside him. So thank you for that, Dr. Garg. And then the Visinate leadership team, which is who I work with in Florida. So really briefly, the Visinate Clinical Contact Center mission statement is that we want to provide regional, modern, reliable services that improve telephone and video access to our veterans. So as I mentioned before, in the Department of Veteran Affairs and the government, for our veterans, access is the main thing. We want to ensure that our veterans are getting access to the highest quality care in a timely fashion. So what was happening prior to the inception of the Clinical Contact Center is that patients were having to wait for exceptionally long periods of time to see their primary care, mental health, even specialty care. And telemedicine just offers one more platform and avenue for veterans to enhance their access to clinical care and not have to physically come into a hospital, to the emergency department and urgent care. And that was the purpose of setting up the Clinical Contact Center. I'm talking about the virtual urgent care that we have set up, but what I also am over is our clinical resource hub. So that's one part of my job responsibilities. Another part is I'm also over all of the clinical resource hub, which is we provide gap coverage in primary care, mental health, and specialty care to Visinate. So as an example, if a provider in Orlando, for instance, goes on maternity leave for 3 months, what happens to the panel of patients that provider is serving? Right now, or prior to the inception of the Clinical Resource Hub, they would have to go to community care, or they would just get dispersed amongst other panels, which, as you can imagine, would lead to increased wait times for the veterans to seek clinical care. So what we've instituted in addition to the Clinical Contact Center is a Clinical Resource Hub, which gives them access to primary care, mental health, and specialty care. So provider A goes on maternity leave while she's out for 3 months. We provide primary care coverage for those 3 months. So that I have a host of providers, physicians, and nurse practitioners that will fill into that slot, be there for 3 months, see the patients just as if that provider was never gone, and fill the gap until the provider comes back. So that's been a great service that we've been able to provide throughout Visinate, and just one more way that telemedicine has been used in the Department of Veteran Affairs. This presentation today is focused on our Clinical Contact Center, which is more tele-urgent care, and I know that's the focus as we're doing more emergency medicine urgent care. But we do provide the Clinical Resource Hub as well for primary care, mental health, and specialty care. In terms of a graphical overview of our Visinate Contact Center services, so we have around-the-clock support. We have, as just a backup in terms of how this works, is patient calls our toll-free number. We have a 1-877-741-3400 number. Veteran calls this number. The first person they talk to, we always call it is a clinical person. They talk to a nurse. The nurse triages them. They're not talking to a clerical support to say, well, I'm here to make my appointment, or I need to speak to a physician. They immediately speak to a nurse. The nurse triages them and determines if the patient needs to go to the emergency department immediately, if they need to walk into their primary care for an in-person appointment, they need to go to an urgent care, or if they could wait for a virtual visit with one of our providers. I lead a group of providers that's 3 physicians and 3 nurse practitioners. We're now expanding to 14 in the next 2 months as we expand into Visin 7. But those emergency medicine physicians, as well as nurse practitioners who have great experience in the emergency department, see 3 patients an hour. So the nurse sees them, triages them, and says, okay, I think you're okay for a virtual visit. They then pass the call on to a clerical, we call it HAS, which is Health Administrative Services in the Department of Veteran Affairs. And we've got a great team of HAS professionals who will schedule the appointment into our grid. Every day we have a grid of from 7 a.m. to 11:30 p.m. of providers who are available to see the patients at 3 patients an hour. So every 20 minutes, the provider can have a phone appointment in Orlando, they can have a video appointment in San Juan, and then they can have another phone appointment in West Palm Beach, as an example. So we see 21 patients in a day. Every provider sees 21 patients during their shift. It's the government, so we have 1 hour of breaks and lunches. But other than that, for the 7 hours, you're supposed to see 3 patients an hour. When we say around-the-clock support, during COVID, I was on call every evening, just in case if there was a COVID-related concern that the nurse needed to reach out to a provider for. However, we also have the HAS, or clerical support, that's on. We also have nursing support that's on 24/7, and then we have pharmacy. So we see the patient. When we see the patient, we say, okay, we feel that, example, yesterday I had a patient that had presumed UTI. I order the urine, I order urine culture. So the patient goes to their local VA, gives their urine specimen, and the results come back within a few hours. I then follow up with that patient. Let's say I have a slot that opens up, or usually we have a follow-up log. So another provider will go behind me and say, Mr. Smith, I see you gave your urine sample, the results have come back, and we recommend that we put you on an antibiotic or not. But if it is an antibiotic that's required, we have pharmacy support 24/7. So we let our pharmacists know. We all communicate through Microsoft Teams. That's our kind of lifeline in the VA. We let them know that we have a patient, Mr. Smith, who needs this antibiotic that needs to be picked up at the VA. They can also have the prescription mailed to them if it's and overnighted to them if it's before 2 o'clock every day. And then we could also, if the patient says, I don't want it overnighted to me, I don't want to drive 30 miles to go to the VA, I just want to go to my local Publix or Walgreens or CVS, we can do that as well. So it's essentially full service care to our veterans that we can provide. They are able to stay at home from the comfort of their own home. They can speak to a nurse, they can speak to a provider. They have to go in to get their lab work if needed. But a lot of times we're able to manage them from home without any further labs or images, and we can take care of them without ever even having to step foot in a VA facility. As mentioned here, so we have around the clock support. We connect with the scheduler who then schedules them in the provider grid. And then pharmacy is also available to support us 24/7. And then the pharmacist, sometimes if it's a purely pharmacy question, I need a med refill, or I have a question about how this medication interacts with another, the patient can then be sent over to a pharmacist who will talk with the veteran and answer any questions he or she may have. The technology that we use VA Video Connect. So that's how we have a video appointments with our patients. And that essentially is a link that's sent to the patient, it's sent to the provider, and we are essentially going to meet in a virtual exam room. And so there's a lot that we can do through video appointments. Prefer that over phone, and I'm going to be going over some data of what our video to phone rates are. We use Cisco Jabber and Finesse to actually call our patients, so we're not calling them from our personal cell phones. We have CPRS for all those that worked in the VA or currently work in the VA. We still are using CPRS. We have that at all sites. And the beauty of that is that if a patient calls us, let's say my 8 o'clock is at Orlando, I drop my note in the CPRS in Orlando. And then if I have a patient in West Palm, I drop my note there. So their primary care specialist, whoever it may be, can see the care that I provided them during the episodic visit that they had with me. And then they can take it from there if needed. We also have, in our area, we have a lot of Spanish speakers, but we have a great translation service regardless of language. So we have that ability. Then it becomes a three-way call. So we have the patient, the provider, and then a translator on the other line. And then we are starting to institute something called CRM, which is our clinical relationship management, customer relationship management system that's going to be going live soon. The data is still pending. We just actually pushed it out late yesterday. That's probably going to be in January, February sometime. And that's essentially a one-stop where we're going to be able to put our orders, notes, everything in one system. So we're no longer going to have to log into 7 different CPRSs. We're going to just be able to go into CRM and do all of our work. And right now we're at 7, but once we expand to Visin 7 in January, we're going to be at 15 sites. So the providers could be seeing a patient in San Juan and 1 minute in Orlando at the next to their 8:20 appointment, and then 8:40 they could be talking to someone in Atlanta. In terms of the veteran engagement, as I mentioned before, they can call our toll-free number and talk to a nurse. They can do VA Video Connect, which is our video appointments that we have. We're at about right now, and I'll give you the exact data in a few more slides, but we're at about 25% video and 75% phone. You'll ask why such a disparity in the phone versus video. A lot of it's just the veterans' just discomfort with using a video modality and communicating with their provider. They prefer to use the phone, and you'd be surprised, it'll show you our first contact resolution, which is essentially our ability to keep the veterans home and not have to present to an emergency department, urgent care, or primary care, is pretty high. So we can do a lot even with the telephone appointment. And then we also have this VA Health Chat feature, which is essentially kind of a chat feature. It's a link that veterans can click on. And if they just want to talk to the nurse and ask them the questions that they may have, the nurse will chat with them, and then she'll pass it on to one of our providers who's manning the VA Health Chat room, if you will, for the day. Usually that's me, but if I'm not in, then one of my providers will man in the VA Health Chat room. Should a question come up that's quick, that doesn't need a 20-minute appointment, the providers are also doing VA Health Chat in the background. So the clinical contact center benefits are many. So it improves first contact resolution, veteran satisfaction. Our satisfaction rates have gone through the roof as we've opened the clinical contact center. The veterans don't have to go in to see a provider. They don't have to wait for days and months to see a provider. They can see them within the next few minutes. They can call at 8 o'clock in the morning, and the next thing they know, they have a 9 o'clock appointment with an emergency room physician by video or telephone. In terms of it supports the veteran continuum of care, and they have 365 days, 24/7 access to virtual care services. So for instance, Thursday was Veterans Day, and a lot of the clinics were closed, but our volume in the clinical contact center was through the roof because they couldn't go into the urgent cares. Those were closed too. Emergency departments were open, but they didn't want to go there. They couldn't go to primary care. They were closed, but they were able to call the clinical contact center and speak to a provider and get their issues resolved. And I think our first contact resolution for that day was close to 95%. So we were able to keep 95% of our veterans at home. It also alleviates workload from our primary care and emergency department emergency medicine colleagues, and improves access for our veterans. So it's a win-win all around. And I think that's why the president has, I think it was a no-brainer for him to mandate having clinical contact centers around the country. And it's during COVID, and I'll be presenting some of the data from that. During COVID, the clinical contact center found special value in Department of Veteran Affairs medicine access they provide to veterans, because that really kept a lot of veterans at home and safe, rather than presenting to the emergency department and potentially infecting others because of symptoms that they could have managed at home. So during the COVID pandemic, the 2 waves that we had in Florida, we saw a significant increase in the number of calls that we had as veterans called us with COVID-related concerns, and we were able to safely keep them at home. I will say that, I remind our providers that we shouldn't be very cavalier about telling them to take an aspirin and stay home and call us in the morning if they're worried about chest pain. We do have a low threshold to send them to the emergency department or primary care if we have to. But still, you'd be surprised at the number of patients we're able to safely keep at home. And then when we have downtime, so we see 3 patients an hour, but let's say we don't have a patient at a 7:20 slot, I ask my providers to follow up on labs, and then also to do some callbacks of our veterans to check up on those that they may have had a little bit higher or more concern for, and just to make sure that they're okay. In terms of our employee engagement, so I talked briefly about our patient satisfaction that's been through the roof. We use V-Signals, which is a patient satisfaction survey that we send to our patients within 1 week of their interaction with a provider. The scores for us are north of 4. So 4 to 5 are the highest trust factors that you can get. And every month we get anywhere from 4 to 5. Rarely do we get something below a 3. And if we do, I personally call the veteran to see what opportunities we could capitalize upon to improve their access, improve their experience with the contact center. But that's the veteran side of it and their experience. So employee satisfaction results you can see here. So on this left column here, you'll see the Visinate Clinical Contact Center employee satisfaction. And then this is all of VHA, the rest of the country, Department of Veteran Affairs. So we've been 93.68% felt that we were best place to work. As you could see how we compare to the rest of the country. Work group recognition, the personal recognition, you can see we're higher than our VA, the rest of the VA. The fact that the supervisor supports development, that's where I always cringe because I feel like that's my report card in front of my boss. They feel very well supported and they feel that they have the opportunities to succeed. We offer leadership training to our providers as needed. We also offer, as everyone knows, the great benefits of the VA. You get 60 days of paid time off. We have some positions open, so if you know of any providers, please send them our way. But everybody feels that they're accountable. There's great collaboration. There's good communication. They're inspired to work. And it's just more than a paycheck. And you can see where our scores land compared to the rest of the country. And I mentioned this, and I feel that this is very significant because one of the hesitations that I had when I had to work from home, and some of you may know, but I'm very outgoing, I'm very social. And when I was the chief of the emergency department, I always laugh because my office used to be near the coffee shop. And I had so many friends that would kind of come in the office and talk to me, and I just loved it. And then I'd look at the clock and I'm like, shoot, it's 3 o'clock and I haven't done anything, but I've entertained all these people get their coffee while I've been, missing my work and not focusing on what I need to get done. So I love the fact that I could just interact with everyone, and going to work was just a pleasure for me. Obviously kids change things, and working from home, I was worried that it would be isolating, or it would be, I would feel disconnected. And it's quite the opposite. I feel perhaps sometimes more available because we're on Teams. Everybody knows when you're available and you're green. But then, the digital divide is just no longer there. You can easily jump on a quick video call with somebody and talk to somebody in Wisconsin, or talk to somebody anywhere around the country, and you feel connected. So we want to make sure that in the contact center with our employees, although they're virtual, although they're working from home, they can't feel or see or talk to somebody, they are feeling connected. And we've really worked on having internal activities with our providers. We have we do medical grand rounds. We have medical students that now rotate through the contact center in partnership with the University of Central Florida College of Medicine. So I started that last year. So now we're in year 2. So they feel that they're getting medical education. We are publishing a lot of our work. So we actually just got one of our papers published. We found out last week. So I'll be presenting some of that as well. And then, we have brown bag lunches, where we bring our lunches and we bring a dessert or whatever we want to this virtual lunch. And we just talk, and we just, connect with our colleagues. And that's been really wonderful in the contact center. So we've really crossed all virtual boundaries that there may be. And I think that's reflected in our employee engagement scores. So I wanted to present some data with the clinical contact center to give you an idea of our work. So you'll see this is just for a year. So October 2020 to October 2021. You'll see last month we had 1,501 virtual visits. During the height of the pandemic, you'll see in August, we were slammed at 2,000. July, we were also starting to creep up there, but now we're starting to come down. So what this says to me is that the pandemic may have, God willing, it's starting to settle down, but the 1,501 patients that we're seeing is sustainment. It's sustainment that the veterans feel that there's value in telemedicine, that when they call the clinical contact center, they are getting their needs met. They're not just calling to say, well, you know what, great, I'm glad you have this, I'm glad you have these symptoms, but now I have to send you off to someone else. No, we're able to manage them. We're able to order their labs. We're able to order medications if we need to. We're able to place the consult if needed, and it's all resolved. They never had to leave the comfort of their own home. So granted, we did have some significant spikes in our completed virtual care appointments, but then when you see these, like in last year, we had a lot of patients. In December, we had 1,447 patients. Some of this was snowbird, some of it was COVID, but then the rest of this, where you just see north of 1,000, that's all sustainment. I think the veterans see significant value in telemedicine. Now, I'll tell you, I started this position in July of 2019. And when I started, I was actually at the AAPI convention in Atlanta. And I was on call to do virtual care appointments. And I remember I got one call that day. And my husband and I, Raj is looking at me, he's like, did we prematurely quit your job at the VA? Because you may have to go back. Like, this is potentially, you don't have a job. I was like, I don't know, but let's just hope and pray that this works out. And I think today, looking at these numbers, we went from we had to think about 10 patients in all of July. And today we have 1,501 patients. Sustained, I think, value in telemedicine is what you can see here. In terms of schedule versus completed virtual care appointments, we want to make sure that all of the appointments that our HAS team schedules, we're able to complete. So you'll see in the month of October, we completed about 96% of them. So what accounts for that 4% delta? That essentially are those patients that were no-shows to their appointments, or they didn't have the correct information in the chart, so we couldn't contact them. The no-shows, we actually have a system where we call the patient back in real time. So let's say I had an appointment with Mr. Smith at 10:20 in the morning. He didn't come to his video appointment. I do have my providers call the patient 3 times. It takes 3 calls before we make a patient a no-show. So once they call the patient back and they no-show to their appointment, I have my HAS team call the patient back immediately and see if they can reschedule the appointment. That essentially avoids the need for retriage because the patient's scheduled within the next few hours. Essentially, the no-shows in the virtual world and the clinical contact centers are left without being seen in the emergency department. So the patient was triaged by nursing. They're waiting in a virtual room. They have a proposed potential time with the provider, but they don't physically, they leave before being seen. And so that's considered a no-show. And that's why we are so aggressive in following up and seeing if we can reschedule the patient or if we have to retriage the patient. to have another virtual appointment if they continue to remain stable. Sometimes what may happen is their conditions worsen and they don't wait for the appointment and they just go in for face-to-face care, which is fine as well. This is our yearly appointment comparison rate. So you'll see October of last year, we were at 1,130 completed appointments. And then this year we were at 1,501. So a significant increase in the number of patients that we've seen just from last October to this October, a 33% increase. In terms of our disposition, so one of the indicators we really look heavily at, and what I look at every morning when we send out our daily reports, is our first contact resolution. We want to make sure that we're managing our patients as safely as we can at home. I always make sure that our providers shouldn't feel that I have to keep this patient at home, otherwise our FCR will drop. No, that's not the goal, but if we can, let's try to do everything we can do, right? We can try to order that medication, try to order that lab, that consult, so we don't have to send the patient into their primary care, urgent care, ED for care. October, you can see we were at 82% first contact resolution. And that's essentially where we are about every month. Some days we're as high as 90%. Some days we even reached 100%, where we get all of our veterans at home. But on average, in October, we were at 82% first contact resolution. This is October broken down by day of the month. And what I'd like to point out here is, one would think that the busier you are, the lower your first contact resolution is, right? So we're very busy. We're seeing 3 patients an hour. And so at some point, the providers will just go to the emergency department, go to the primary care. I can't manage you. I've got the next patient I've got to go to. We don't want that. If that's the case, then we're seeing too many patients an hour. As the country stands up the clinical contact centers, the president has put in his manual that he wants us to see 2 patients an hour. But we're doing fine at 3 patients an hour. And why, impact access for our veterans if we can continue the pace? But I look at this graph, and what it shows me is that our first contact resolution is independent of the number of patients we see, which is good. So you'll see on October 2nd, we had 32 patients and we had 78% first contact resolution. So that means we really are managing our dispositions based on the clinical context and not on our volume. But then there are days that, October 22nd, we had a very high number of patients and we had 91% first contact resolution. So our FCR is independent of the volume of patients that we see every day, which is what we want and we want to maintain. If we start to notice that our FCR is going down as our volume is going up, then we need to readdress the 3 patients an hour that we're seeing. But we're managing to do it all right now, so we'll just continue that. In terms of our year-to-date first contact resolution, we're at 77%. So 77% of our veterans who've called the clinical contact center and have had a virtual appointment set up with our providers have been able to stay at home. 17% of them have been referred to their primary care or emergency department for further evaluation. And then the remaining 6% are no-shows or incompletes. As I mentioned before, we look at the virtual care appointment types. Obviously, I always push for video because I feel that there's so much more that you can see in video as opposed to a phone. But ironically, we've actually done well. And those studies to date, we've done significant lit reviews to see if you would think that if it's a telephone appointment, your first contact resolution would go down because you can't visualize as much as you can if you were physically or visibly seeing the patient. They've actually shown there's no correlation. And in one of our studies that we did, we looked at the modality of patient appointment and the first contact resolution, and we found no correlation. But we still look at it. We have 75% phone appointments and 25% video appointments. This is just a quick graph of our hourly volume. And what it shows here is that we're busiest between 10 a.m. to 6 p.m. And like we do in the emergency department, Dr. Garg will tell you, we always make sure that we match our staffing with our volume, right? So here you'll see that we're busiest between the 10 to 6 p.m. hours. So that's when I have 2 providers on during that swing shift. So I have 1 provider coming on at 7 in the morning. I have 2 providers coming on from 10 to 6. And then I have 1 provider closing down our shop from 3 to 11 o'clock in the evening. And then the weekends, you can see there's really no rhyme or reason. It depends on when everybody wakes up. That's this orange bar that you see here. So I just have 3 providers on. I have 1 provider on in the morning, in the afternoon, swing shift, and the evening, because I want to make sure that I conserve my human capital resources and provider energy for the weekdays when we're the busiest. One thing that we look at very closely is our virtual care slot utilization. So we can have slots available all day long, but are they being utilized? And that's an issue that we kind of grappled with, if you can see, in April, May, and June. We had about 50% of our slots being utilized. So 50% of the time, the providers are doing follow-ups, or they're calling back the veterans to make sure that they were okay after their initial appointment. But we really wanted to increase that. There's no point in having a service that's not being used. So you'll see that in September, we had 82% slot utilization. And how do we do that? Well, COVID definitely helped. We had the confounding variable of COVID. But what I did was I worked with my chief nurse, Ms. Teresa Mont, and we looked at missed opportunities. So during this downtime, when we had the 50% free time, the providers combed through the charts of all of those patients that nursing triaged in the clinical contact center who could have potentially been eligible or been suitable for a virtual appointment. And what we found that we had about a 29 to 32% missed opportunity rate. And what that meant was we were losing out on 29 to 32% of our veterans that we could have referred for a virtual appointment. Just by that one exercise alone, you can see that we went from 51% of slot utilization in May to 73% in July. And then in August and September, we only crept up. I always tell everyone that I'd like to take the credit with Ms. Mott for our pilot that we did on missed opportunities, but I think COVID helped us a little bit in increasing our slot utilization. We also do a lot of cross coverage. As I mentioned before, I'm heading up the clinical resource hub. So I have primary care providers as well as mental health and pharmacy, and we're expanding into specialty care. But when I have primary care providers, I look at their schedule every day. If they have open slots, I ask that they cover in the clinical contact center. So if I have a provider that doesn't have a patient from 8 to 10 in the morning, I ask that he or she work in the clinical contact center, and they see 3 patients an hour. So you get 6 more slots that the provider can, that we can increase access for our veterans. So you'll see here that of all of our slots, I look at we've used 75% of them. Of our cross coverage, the CRH providers that cross cover in the clinical contact center, we use about 42% of those slots. And if you just look at just the CCC providers, the 6 providers that I have, 77% of the slots that we have are utilized on a daily basis. This slide just gives you a hopeful trend of the COVID-19 related cases that we've seen in the clinical contact center. We were very high in August, we decreased in September, and we're at 14% last month, and we're only decreasing this month. So this trend is a good trend we like to see. We also want to make sure, as I mentioned before, that we cover Visinate. I say Visin 7 because we're merging with them, and that's kind of where the bulk of our work is right now, just trying to make sure that we have a seamless transition. But with Visin 8, we want to ensure that the patients who are calling the clinical contact center are represented throughout the Visin. So not only is Orlando calling, but we have folks calling from Miami, from Bay Pines, from West Palm Beach. And you'll see that it's not evenly distributed by any means, but when you saw the graph when we first started, it was really all Orlando patients. I came from Orlando. I think I marketed there heavily. And we saw the majority of our patients coming from Orlando. But now you'll see there's a better distribution. So there's Orlando. We also see a significant percentage of patients from Bay Pines, from Tampa. There's opportunities from Miami. That's always our smallest group of veterans, as well as the Caribbean. But that essentially is just proportionate to the number of veterans that are in those areas. But we do have a healthier distribution of the patients who are calling the contact center around the visit. And then we always value ourselves on the engagement that we have with our pharmacy and our nursing team, as well as HAS. So I told you we use a Teams channel. So this just shows our engagement that we have on a daily basis with our pharmacists, our nurses, and then HAS, we don't have a Teams channel with them, but we're very engaged with them throughout the day. So as I mentioned before, I say that the clinical contact center is a virtual urgent care, but we really have tried to establish ourselves as a virtual academic medical center. So with that, there's a 3-pronged approach of clinical care, research, and medical education. We do a lot of research. This article is just one of the articles that have come out through the contact center and through Indus. Under Dr. Galwanker's leadership. And then it was great to collaborate with my colleague, Drs. Garg, his wife, as well as Dr. Manish Garg. And I'm going to go through this briefly, but Dr. Garg will be expanding more on this. And then also I'll go over another paper that we just had accepted for publication regarding the impact that the clinical contact center made during the COVID pandemic. So this is the research aspect. We went
Veronica,
Yes.
hi, Veronica, sorry to. So can you wrap up within the next like 2 to 3 minutes, please?
Yes,
Because
sir.
thank you.
I will. Yes. Sorry. So as I told you, this is the research aspect of it. We also have medical students that rotate through the clinical contact center. And we obviously have our main emphasis, which is clinical care. So this is one paper that we worked on. So I appreciate the collaboration. And this is a recent publication that went out in JETS. These are the 4 pillars of telemedicine. And I'll can read the paper. And I think Dr. Garg is also going to touch on this. Another one is we had a paper published regarding the work that we did in the contact center during the COVID-19 pandemic. And then this is just some background on that paper. And you can see how our numbers significantly increased during the COVID-19 pandemic, but what our first contact resolution was still very high. And then this is some logistic regressions that we did as part of this study. Essentially, we found that patients with COVID-19 related chief complaints that use the clinical contact center were more likely to remain at home and were less likely to present to the emergency department, which is what we wanted. And with that, thank you for that timer, Dr. Chakrabarty. Are there any questions?
Thank you so much, Veronica. I was so engrossed in your talk, I didn't even look at the clock myself. It was an amazing presentation and shows your passion for what you do. Your passion really exudes through your speech and talk today. I really appreciate you coming and sparing this few minutes with us. And over to Stella for questions.
Thank you, Dr. Sikka. That was an amazing presentation. I think everyone, like you mentioned before, is aware that the VA was one of the first healthcare systems that actually implemented telemedicine. So my first question was, how do you feel VA patients have responded to telehealth versus having to, obviously it increases access of care, but do you feel there's been a positive or negative response to more virtual opportunities for health access?
Dr. Gandhi, that's a great question. I think the veterans have definitely embraced virtual care with open arms. There was initial hesitation, as I mentioned, when I came to the Atlanta AAPI convention in 2019. I think they kind of thought this was kind of like, okay, so I'm just going to call this number, because there is a perception that veterans feel that sometimes they do get neglected, right? In the Department of Veteran Affairs, they have extended periods of time that they have to wait for primary care, specialty care, appointments. So, is this just one more way that I'm going to have to wait to get access to a provider? So there's like, okay, I don't think they bought into the concept. So I marketed heavily to our veterans during our town hall meetings. And then it's also just word of mouth, so Mr. Smith called the contact center and he got his issues resolved and he got his medications mailed to him overnight. And he tells his friend, Mr. Jones, and the next thing it spread like wildfire. I think that the slide that shows our volume, where we went from, you didn't see it back in August 2019 or July 2019 when I was questioning my job security. You could see the significant increase that we've seen in the number of virtual appointments. I think veterans have embraced it wholeheartedly. Their feedback has been wonderful. We did our own survey. We did kind of our own Likert scale survey that we would call the veterans back to see what their satisfaction was. And then that we recently transitioned over to V-Signals, that they actually, a third-party company that actually does those surveys for us. And all of the feedback has been north of 4 to 5, which is the trust factors that show the highest patient satisfaction.
I completely understand your hesitation for job security. When I started telemedicine back in 2016, it was definitely not quite as popular as it is today. And so I questioned myself a little bit in the beginning as well.
The COVID pandemic helped us, I think. I think it definitely put our mark in the sand.
One of the questions I always get asked is, does it reduce the quality of care for patients to do a virtual visit versus a face-to-face visit? Your thoughts on that?
Yeah, again, a great question. We would think, right? Like you can't really do much because you're just, I'm here and you're there. And what am I going to be able to do for you if I can't listen to you, or if I can't, put in medication in for you and order for you? Well, we can. So there's several things. One is, I can put in all the orders that a veteran may need. I can put in their medication, their labs, their images. Even if they say, I've got this wrist pain, I fell, but I could still move it. It's probably nothing. But you can even put in an x-ray of the wrist and they can go in and get it done. But you can say, oh, by the way, just pick up a brace or a mobilizer on the way out. So I think there's significant value there. And, we've had our providers do something called CBT, which is the veteran comes into this is a pilot that we did with Orlando. The veteran comes into the emergency department, and we looked at those lower acuity patients, the patients that were acuity 4s and 5s, the colds, coughs, sore throats. And rather than seeing an emergency provider, we had a provider in triage that would say, yes, you're actually a good candidate for a virtual appointment. And they would come into a room, they would think they would see a provider, but they would see one of us on a monitor. And with that monitor, we had a telewand, a teleotoscope, a telestethoscope. So we were able to look in their ears, hear their heart, a telewand, so we could look at dermatological complaints. So I think that really helped. I think if we could pivot and enhance the care that we provide, I think it would be nice to have that extra added layer of patients potentially coming in and having a CBT appointment, which is where we can use those additional peripheral modalities. And we are working on that.
Great. For me, I found that patients tend to be more amenable since they're no longer having to take the day off to come into the office, pay a copay or whatnot, any additional hurdles that they may have actually going in for a in-person visit. So if you have, like you said, for lower acuity, if someone comes in with a cough, cold, most of the time these things are viral. You have this discussion with the patient. When they've had a virtual visit, they haven't wasted an entire day coming in for that. So you say, oh, why don't you see how you do doing this, this, and this, and then call me back or schedule another appointment in 2 to 3 days if you're not better. They're more amenable to that versus if they come into the office, they feel entitled to get an antibiotic prescription or a steroid prescription or something because they've taken the time to come in. So I think quality of care actually from that standpoint, from a medical standpoint, is actually much improved. Some other questions from the chat box have been, some private insurance companies have stopped paying for telehealth services. So the ease of billing and reimbursement has become a major challenge for physicians. What advice can you give to private practice physicians who face these challenges?
Well, it's funny that you mentioned it because my husband's in private practice. He's in GI, so he does telemedicine clinics on Thursday afternoon, and he comes home and does that. There was a time during the COVID pandemic where his office closed and he couldn't scope, and all he did was telemedicine. And it was great because they were getting reimbursed at the same rate as if they were having in-person visits. Now that's gone down. It depends if it's the insurance company. So, in terms of advice, you can't, insurance companies are what they are. You can't force them to pay for a service that they're not going to agree to. But I do, I think it's all data driven, right? It's a no margin, no mission. If they don't see the money, the insurance companies are obviously not going to pay for it. So, what his practice has done, and I've kind of encouraged his practice to do is show them the data, show them how you're able to increase access to care for your patients, and how it's actually cheaper for patients to do telemedicine for exactly the reason that you mentioned, Dr. Gandhi, because you know what? I didn't have to wait for that doctor for an hour, and he just told me to take a Pepcid and just wait it out. Now I'm okay with that as opposed to pushing him to do endoscopy on me. So I think the patients are happier. It all just kind of comes down to data, and I think his office has done that, and some insurance companies have been amenable to continuing telemedicine. Obviously, as things start to open up, we can't do 100% telemedicine like we did before. But I think the insurance companies that are pushing back, that's all data driven. It's unfortunately all margin driven. So if you can show them that first contact resolution, those results of how you save them money by doing a telemedicine appointment, it may be worth a shot.
Yeah, absolutely. One of our other questions has been, can you provide errors of omission that may be committed by doing virtual visits in elderly patients since they have multiple complex medical problems?
I'm sorry, what is it?
Sorry.
I missed that. I was reading the chat box.
Have you noticed an increase in errors dealing with the elderly when they have multiple complex medical problems?
Yeah, sorry.
Okay.
Our mentality, do one thing at a time. But no, we haven't. Actually, the PA is great because we have CPRS, so we can see all of their medical history. We can see the medications. That's been, I think, if you do a successful telemedicine program, you have to have a good EMR where you can see the patient's record. So you know that they saw Dr. Gandhi 2 months ago and she prescribed these medications, and now this patient is coming in with this. So if you have a good EMR, regardless of the amount of comorbidities, because we do have a significant geriatric population, the majority of our patients are, although we'll say the veteran population is moving toward, middle age, younger, as well as females. If you have a good EMR, you have good documentation, then we can manage accordingly. Plus, we have multiple layers, right, that we're managing our veterans. We have the nurses who are speaking to them, we have the providers, and we have the pharmacists. We have all these clinicians that are involved in that episodic care that we provide the veterans. So it really alleviates any medical errors. I can say to date, knock on wood, we haven't had one instance of a medical error or an issue where we told the veteran to stay at home and there was a negative outcome. And we do track that closely. The government, if you have like a patient that, God forbid, had an appointment and then expired or did a bad outcome, we have to respond to that. And we haven't had that happen with our virtual care visits.
That's fantastic. Another question is, does the VA offer specialty virtual health visits, like nephrology or pulmonology?
They do. Yeah, they do. They are expanding into that. Teledermatology is big. Surgical specialties, subspecialties are starting to expand. So, right now the big things that I'm over are obviously the clinical contact center. And then in the CRH, I do primary care and mental health. I just hired a chief who works underneath me because I don't have much mental health, obviously, experience beside the emergency medicine, like extreme. But we have mental health services that we provide, and we're thinking about expanding into specialty care like dermatology, those that are amenable. We have teleretinal services that we provide in Visinate as well. So there's definitely going to be continued expansion.
And as a provider providing clinical virtual health, do you feel that there are any limitations, or what would you like to see become available within the next few years to improve virtual healthcare visits?
As I mentioned before, I think video is very important. It would be nice to have more video appointments. There's just so much more you can do by this interaction that, their eye is pink. Well, how pink is it? Is it, it's all different variations. So being able to encourage video appointments is very important. I'd also like to see some patients in the emergency department who come in, the lower acuity patients, that we can see with the Tele wand, ophthalmoscope, as well as the telestethoscope. I think that helps with our physical exam. So I just want to have a more robust virtual care experience for our veterans. So not only telephone, but we should have video as well as in person. So if they do come in, rather than waiting for hours in the emergency department to see the provider who's dealing with the code, they can just go to a telemedicine provider who can provide the same care that in-person ER physician can provide.
No, I think that's fantastic. And I know there's a lot of these devices out there. I myself have worked with some of these stethoscopes and otoscopes and everything. And so it's fantastic to see how far and how much potential there is in telehealth. And so I'm hoping for the same thing here. I just want to thank you for an incredible presentation and an introduction to telemedicine in the VA. I will hand it back to Amit at this point.
Thanks, Stella, for doing such a wonderful job. And there are some more questions for Dr. Sikka. Please put them on the chat box, and Dr. Sikka will actually reply. Put it for everyone, not just personally for her, so that everyone can benefit from her answer. And Dr. Sikka, please note the chat box. And if there are any further questions, please answer that. In interest of time, we have got so many other questions. In interest of time, we'll move on. And thank you very much again. It was great. The only thing which I may have one question is that in some areas, especially rural areas, video is a problem because of internet connection. And that has been an issue. I'm sure that will get better as we move on. But that's something which I've noticed. So without further ado, let me introduce the next speaker. It gives me a great privilege to introduce another great stalwart in telemedicine, Dr. Manish Garg. He is the professor of emergency medicine, residency program director at Weil Cornell University and Columbia University and Vagelos College of Physicians and Surgeons. He was the past president or ambassador of collaborators and the co-founder and board of governor for American College of Academic International Medicine. He is also a co-founder and governing body member for the World Academic Council of Emergency Medicine, co-founder of Accreditation Council for International Medical Programs. He has got so many hats that he wears, and he's very, very accomplished, as you can see from his bio. He was a previous dean for global medicine and a co-founder for multiple international organization, expert legal witness, and radio, television, media commentator. So, and he'll share his knowledge and experience, and he has contributed to the AAPI over the past several years. In fact, when I Googled him, I saw all the talks he's given, not Googled it, I just put it on the search bar on my Yahoo, and I saw so many other talks he has given for AAPI, and it's a great privilege to have somebody, it's almost like a shining star, to deliver his talk today on medical legal pearls and pitfalls in telemedicine, because as we are embracing telemedicine more and more, we need to see what other, what are the legal aspects of this. And so over to you, Dr. Garg.
Thank you, Amit. I really appreciate that amazing introduction. And I just wanted to really commend my colleague, Dr. Veronica Sica. That was an amazing talk. So happy to be with you all here today. Let me just pull up my talk here. Okay, so, and just let me know if you can see it okay?
Yeah, we can, yeah.
Okay, great. So I appreciate this really generous opportunity. I'm gonna, just based on the way I have my setup here, I'm gonna look both at the camera and I'm gonna look at, I see people that I'm looking at here on the side. So I really love that feedback from the audience, see your faces. And it's really wonderful to have an opportunity here to speak with AAPI and also just my esteemed colleagues. I think, you know, being Indian background, I think this is really, really important that we have a shared sense of community, that we're able to do things together. You'll also notice, in addition to my background with Weil Cornell, New York Presbyterian in Columbia, just like Amit had mentioned here, my association with the American College of Academic International Medicine and the World Academic Council of Emergency Medicine. So very, very excited to be here today. And I also wanted to, I know it's a little late, but I wanted to wish you all a belated happy Diwali for those who observed. Had a wonderful time with my folks who are on the call today, but also who were able to come visit me and my wife and my 4 kids. So I have no conflicts of interest that I'd like to disclose here, no relevant financial relationships. I think it is important though that you know that I have received some slides from our Center for Virtual Care, as well as from Dr. Peter Greenwald, who is our director of virtual care at Weill Cornell Medicine, and I've given attribution to those slides. I just wanted to give you a little background of how I ended up here in this particular experience. So yes, in 1998, I was in YPS and the MSRF exec board. So dating myself a little bit. And thank you, Amit, for talking about my many hats. I need my many hats to take care of my loss of hair. So yeah, it's been wonderful to see how much AAPI has expanded and how much utilization there is. And I have a real fondness and love for this organization. During the pandemic, there was a lot of bi-directional collaboration with India, and we were a lot of folks of Indian origin that we were involved with while we were dealing with the pandemic. And so in my work with the American College and the World Academic Council, we very much necessarily did activities that led to saved lives, both in India and the United States. And so it was really wonderful to have that bi-directional communication. We did that throughout the world, so it was really, really special. My background also, I mean, the pandemic was almost kind of a reckoning for me because of my background as an emergency medicine doctor, my interest in global medicine, as I've been very lucky to have wonderful mentors and folks who gave me opportunities. And then my research from NIH and CDC looking at emerging infectious diseases, COVID actually became something that was very, it's almost something that I had been preparing for my entire life. And with regards to medical legal, I've been, as Amit mentioned, of an expert witness background, and I've been able to advocate for physicians. And that's one of the things that I'd like to do today. I think, when we talk about medicine, there are wonderful aspects about it, and we really don't like to discuss all of the regulatory aspects, but I think it's critically important because we need to make sure that we're practicing preservation in addition to our promotion. So the objectives, I want to discuss telemedicine at our institutional level at Weill Cornell Medicine, and then also some of the work that's been done with the CAIM and WASM. And then I also want to talk about some of the ethical concerns about telemedicine as it relates to informed consent, autonomy, standard of care, data management, confidentiality, doctor and patient relationship. And so I'm hoping that we can do a couple of case examples, just a little fun, little interactive, and then I can give you some practical solutions. But because I know we're all coming from different shops and we're all coming from a different background, but having some practical solutions that'll help you on your day-to-day, I think will really be well received. So the next 9 slides are from the Weill Cornell Medicine Center of Virtual Care. It is a center of excellence for education, clinical care, and research. Basically, they use a multimodal approach from the emergency department. You can see express care. So if you are a patient who signs in and calls into telemedicine, you might actually be seen by an emergency physician using our telemedicine apparatus. We also use the virtual urgent care, just like Veronica had mentioned. We also have ED medical screening exams for patients who are then going to be taken care of by additional providers. And then interestingly, we use the virtual care to have our paramedics go out to see the patient. So it's a community teleparamedicine outfit. But you can see here the education, clinical, and research kind of 3-ball Venn diagram. And I want to talk a little bit about that. What we try to teach at the center, and what I think is really important for anybody who's interested in doing this, because one of the things that the board here asked me to do today is to note that we have people who have had a various experience with telemedicine, some who are just starting and some who are very, very experienced. So we wanted to talk, how do you learn these skills? So it'd be really important to go to a center, go to a place where you can learn these skills. At our particular center, you can learn the basics of telemedicine. They've got this fun phrase, you can learn website manner. We'll talk about how you're supposed to do the evaluation remotely. Like, how do you do an exam on somebody who's not in front of you? How can you develop that skill set? It's not necessarily intuitive. And then they also have specialty specific modules so that folks can get adept at doing things that are in different specialties. Again, you don't want to go outside of the scope of your practice, but you want to make sure that you have the depth and breadth of that practice. From an education and research front, because I am an educator as the residency program director for emergency medicine at both Cornell and Columbia, obviously this is a passion of mine, but real-time resident supervision is something that we're able to do in telemedicine. Core procedural teaching, remote simulation exercises, specialized trainings, asynchronous mentoring. So that's become a big thing in my work in global medicine. We do telementoring. We in fact have a relationship with Weil, Bugando, Tanzania, and we have a virtual classroom, which is very, very exciting. So once a month, we have the folks come from there. Love to be able to do that at some point with outfits in India, if that's possible. Case advising, remote delivery care, asynchronous case content. So lots of opportunities for us to involve ourselves with telemedicine and teleeducation. And how does this translate? Well, we started a curriculum in teleeducation. It's pretty exciting. We have our teachers be able to talk to med students, be able to talk to other trainees, and then, all the way up to our resident trainees. And so we've developed a curriculum, and we have our residents right now go through a longitudinal curriculum where they can learn all of these important telemedicine practices. Now, for those of you who are already out there and already been done and completed, there are these different outfits that'll be able to teach you telemedicine skill sets so that you can take care of patients using this platform. Now, talking about clinical medicine, because I think that's probably what most of you would be interested in. If you look at this particular graph here, you can see, with the age distribution of folks that are most likely to use telemedicine. So for patients who are much younger, obviously, only recently was the vaccine available. So there was a number of younger patients who parents were concerned about, didn't want to bring their kids into the emergency department or into their primary care or specialty care areas. So they were utilizing telemedicine as a part of this bimodal distribution. But you can see for the most part, from the age of 20 to the age of kind of like in the 50s, that's generally the patient population that you're going to see that are interested in telemedicine. As we get more senior, as the baby boomers continue to get much older, you're starting to see more adaptation and use of telemedicine. But I think that's really important, both for us, from the patients you might see, and those of us who are over that age of 50 who are trying to use telemedicine as a platform. So it's just kind of good to know who is facile with technology. And I think it's important that it's something that we all learn and all try to use each day, because technology and advancements in technology are going to be expected for the future. Taking a look at this slide here, this is a map for the area of New York City, actually Manhattan, you can kind of see in this area. So this slide shows the utilization, and I don't know if you'll be able to see it, but you can see that there's almost 3,600 total cases as of April. So in New York City, the pandemic really hit us terribly in March and April. And then here you can kind of see 15,000 total cases if you start looking around at the total zip codes of people who had gotten COVID. Now, one of the things about this particular slide is it really does speak to the healthcare disparities. A lot of the folks that are in Manhattan have a lot more resources versus the folks that are in some of the other boroughs. And so it's important to note that you may have patients that may not be able to afford this platform. So if you want to make sure that your patients can get access, you have to be creative in how you might provide a discount for a patient to be able to come see you throughout this platform. Now, with regards to physicians and telemedicine, especially when the pandemic first happened, you can see that, for all of those of you who are in different fields and specialties other than the ones that Veronica and I are in emergency medicine, we were able to get uro, reproductive, derm, psych, PMNR, OBGYN, radonc, radiology, ophthalmology, neurosurgery, neurology. All of these folks at the very beginning of the pandemic in March, there were about 50 plus folks that we were able to onboard in the first few weeks. By the end, we had over 100 providers that we were able to onboard during the pandemic. And I have to tell you that before the pandemic, there was probably about 30 visits a day. So just to Veronica's point about how the pandemic really has made the mark for telemedicine and telehealth, there was about 30 visits a day for us that ballooned to 300 to 400 visits daily. And if we didn't have that 300 to 400 visits daily, basically able to siphon off the patients that were coming to the emergency department, it would have, basically that prevented our health system from volume overload or just system collapse. So it was an incredibly important, nimble resource that we were able to utilize at the time. And how do patients and how do physicians accept telemedicine? Well, it looks like they accept it really well. My wife's a family medicine physician, and you can kind of see here, looking at this graph in family medicine, that as March and April of 2020 started to come, the in-person visits really started to come down. And you can see the telemedicine visits really started to come up. But what I think is really important is this section here, right here of the graph, right? So you can see that, when you look at the claims data here, it's pretty steady and this plateau, but now you're starting to see in-person visits starting to come down as we approach here, in November. Well, this is November 2020, but when you take a look here of the telemedicine visits, it's still at a threshold of 100,000. And I think that that's really important because it shows you that telemedicine is really here to stay, and it is the wave of the future. And you can start seeing that patients are beginning to prefer this modality over their normal modalities. And that's true. When we look at some more data, this data came from the American Medical Association Research Perspectives of Telehealth in 2020 survey. You can see that in 2018, use of any telehealth was about 25%, but now 2020, it's 80%. I'm sure that data is even higher now. And you can see in terms of video conferencing, storing data, remote patient monitoring, all these are in the tens to teens percent. Now take a look at where they are now. It's incredible how much this has really, really ballooned. And even if you continue down and take a look down, whether it's chronic care, like chronic care has really, really increased in terms of the telemedicine visits. It's gone from just under 10% to almost 60%. So there's been a lot of adopting and acceptance of patients for this type of platform. So what have we done? And this is what Veronica started to touch on. We realized right off the bat, as part of our researchers in our network of the American College of Academic International Medicine and the World Academic Council of Emergency Medicine, both of these outfits are sibling organizations that Dr. Gallwunker, my colleague who's on, also like a brother to me, he helped to co-found these organizations. And what they're basically doing is they're getting physicians together, trying to make a huge difference within the world in terms of increasing consensus statements, in terms of clinical care, in terms of trying to make sure that we're following best practices. And certainly with the World Academic Council and our integration with a lot of different countries, we've been able to share data, share information. And so this particular article that we put together where we leveraged, talking about leveraging telemedicine to optimize care with minimizing exposure, it was important that we started putting things out in the literature so that other communities would adopt this practice early. So myself, Sagar, a number of physicians of Indian origin participated in this particular research paper. This is the one that Veronica spoke about too. So we recently put this particular article together. Veronica was the lead author and I was one of the senior authors. This is a collaboration with the World Health Organization in Southeast Asia, looking at a framework for using telemedicine technology in healthcare institutions. And if I kind of get down a little bit more into detail here, telemedicine is at the nexus of the care of the patient. You know, whether you're talking about all of the individuals, whether you're talking about transport, whether you're talking about command services, essential services, post-care mental health, medical monitoring, you know, logistics and supply chain, it all kind of comes back, and telemedicine is at that nexus point. So the 4 pillars of telemedicine, this is probably the most important section of our manuscript. And I highly suggest if you have an opportunity to take a look at our manuscript, we'd identified that there were really no quality or no reliability measures for telemedicine. So that was the impetus for putting this particular paper together. So we distilled these 4 pillars. They are patient safety and confidentiality, number 1, metrics, analytics, and reform, number 2, recording of audiovisual data as a health record, number 3, and reimbursement and accountability, number 4. And so, of course, in the manuscript, we take a deeper dive into each pillar and provide the background necessary to understand how to navigate the telemedicine practice. But I'm going to take this and I'm going to basically use it to talk a little bit about my talk for the day. And one of the things that, you know, when we were thinking about in our research group, you know, what did the future hold? Well, the future holds a lot of innovation. I think that's where telemedicine is taking us. You know, telehealth, I think, is just the beginning. You know, you're going to see an incorporation of telemedicine, blockchain technology, artificial intelligence, machine learning, stereolithography. And for those of you who don't know what that is, that's 3D printing, virtual classrooms, virtual mentorship, virtual care. This is really the wave of the future. And so I think it's important for all of us to be aware of this and to try to make sure that we are keeping an eye and learning all of the best practices associated with it. So, you know, telemedicine, right? Sounds like an incredible utopia. And of course, I would endorse that as physicians of Indian origin. I think we are perfectly poised to be at the epicenter of this new wave. Our understanding of medicine, technology, and business, combined with our drive for success and media exposure, certainly forecasts well on this particular platform and in this arena. But what I really hope for this particular talk is that, you know, we really help you to better understand how we can do this safely and protect ourselves as we participate in this promotional process. We also had put together about this particular talk a topic on international health security, taking a look at some of the top security issues that are there. And if you take a look, I mean, certainly there's many different things from biochemical and warfare type things to infectious disease and food insecurity, but health informatics and cyber health, that is really one of the things that's very, very important. And it's become a critical issue. And I think that's why it's important to talk about it. I know it's like one of those things when you talk about insurance or you talk about indemnity or you talk about where your risk is. I think it's really important as physicians that we protect ourselves from this risk, because this is going to impact you both personally and professionally. So I think you need to be properly educated about the rules and regulations as it pertains to maintaining your physician practice. And also you need to protect yourself from any cyber criminals who are really, really good at phishing attacks, hacking, and ransomware. They've done surveys where they've looked at the dark web in March and April of 2020, and they found like 140% increase in words and phrases that are related to the kind of future innovation of cyber technology. So it's important that we do the things that we need to protect ourselves. You know, more important than your individual bank account, these types of hackers are trying to get access into patient health information, which is actually more valuable. So that's become a prime asset. So in this particular manuscript, I was able to create this particular infographic that looks at safety and surveillance, if you can kind of tell, utilizing a prevention, detection, and assessment strategy. And then, you know, how do we prepare ourselves from an action standpoint, looking at reporting, response, and addressing needs? These are the important mitigation strategies that you're going to need to learn. And I'm hoping that in the talk today, we'll be able to touch on some of these points. So why don't we just clear the slate here? I wanted to go through an example with you so that you can kind of get a feel for this experience of telemedicine. So let's suppose you had a patient who presents with a sore throat, and I'm the one who's doing the telemedicine visit. So, you know, I would tell this particular patient, hi, my name is Dr. Garg. I'm working at Cornell Medicine or Columbia University College of Adjunct Physicians, and I'm happy to take care of you today. Can you present to me, you know, exactly what you're here for? And the person might say, I'm here for a sore throat. Okay, great. And I might go in my mind and start thinking about different criteria about whether this person may or may not need antibiotics. And so I'd say, you know, hey, have you had a fever? And the person may tell me yes or no. And I would then ask, do you have a thermometer to help check to see if in fact you have a fever? And so maybe they're able to provide that thermometer, maybe they're not. Then I'd ask them if they could tell me if they've had a cough. You know, if they've had a cough, then it's more likely to be strep. And if they've had a cough, it's less likely to be strep. If they haven't had a cough, then, you know, sorry, let me say this again. If they had a cough, it's more likely to be some other viral illness. If they haven't had a cough, then it's more likely to be strep. And then, you know, in terms of having them feel, now this is a hard thing, right? How would I have them feel for anterior lymphadenopathy? Well, I'd tell them to touch and around their neck, under their mandible, right above their clavicles to see if they have any lymph nodes. And so, you know, if they say yes, yes, yes for all of the different things so far, and then I would have them take a look, and this is probably the most difficult, right? But I would probably have them say, hey, can you have me take a look inside your throat? It'd be nice if there's a wand, like what Veronica's talking about. Otherwise, I have to do something where I'm having them back up like this. And it might be more than you wanted to see about my throat, but the reality is that's how we would make an assessment to see if there's any tonsillar exudate. So let's suppose you have 4 out of 4 of your Centaur criteria and you've decided this person, in fact, does have a sore throat, probably a strep throat, and you want to give antibiotics. So then you make the decision that you're going to prescribe antibiotics for this patient, and then, you know, you go forward. Now, this sounds like a normal visit, but there's a number of things that I didn't assess for to try to make sure that, you know, I would be safe in this particular practice. And I'm going to get to that later. What if this patient wasn't in the same state that I was in? And although called me in New York City, because maybe that's where they go to work, but the person actually lived in New Jersey, or they actually lived in Pennsylvania. And at that point, then I'm trying to write a prescription out in another state. And I think that's really where some of the problems come from telemedicine and making sure that we are adequately protecting ourselves. I'm going to go to another example here. And this actually happened with one of our clinicians who was seeing somebody. There was a patient who came in with profound hypoxia. They had a number of colleagues who had patients with COVID with profound hypoxia. They were short of breath, wheezing. This particular patient ended up having respiratory arrest on the screen while the person was doing the evaluation. And the clinician provider was not an emergency medicine person background. I think the person was neurology. And so they're trying to help with the person. They actually reached out to our internal group because they said, I have a really bad situation happening here. And we had a number of our colleagues jump on the call. They called the local 911 for the patient on their behalf and stayed with the patient and the family that happened to be there. The patient ended up coming to the hospital and unfortunately expired. But you know, what is your risk exposure in this type of scenario? So I want to talk and give you a couple of different concepts and ideas, and hopefully we'll go through this quickly. I think these concepts will help you in addressing some of these medical legal principles. And after discussing with the AAPI leadership about what the experience level is of the audience, I think there isn't a lot of time for a very deep dive, but this is really more of a primer. So hopefully I'll be able to answer some of the questions that come up afterwards, but provide some overall general themes for the audience. So first, I want to talk a little bit about the doctor and patient relationship. I think this is the hallmark of what we care about as physicians. And really, to me, what this comes down to is regulation, licensure, and liability. And where do most people get into problems when it comes to this particular issue? It's accidentally working across state lines. I was reading through my research about an Indian physician who accidentally prescribed something to somebody from a different state. That person ended up having a bad outcome, and then they actually went back, and there was legal ramifications for that physician. Now, it's important to know that classically, state boards are responsible for licensing doctors and healthcare practitioners. So what happens when a healthcare provider practices telemedicine across state lines? Well, that's a real issue, right? And you also have to know that the scope of practice is also determined by the state boards. And that's typically where the patient lives. So one of the questions that I ask for the patient isn't, where is your home? I ask them, where are you right now? Physically, what state are you in right now? And it's really important to know this because laws can vary from state to state. And sometimes these laws can be in conflict with federal law. They can be in conflict from one another. And this is important. This is particularly relevant when you're talking about prescribing and informed consent. And what about malpractice coverage? That's another part of the doctor-patient relationship. And I saw a comment that came up on the screen in the chat about malpractice. Well, many of the policies cover face-to-face encounters within the state. The doctor is licensed in it. And so that's also a problem. So what are my practical tips for you? So one, ask the patient where they're physically located during the call. Two, understand your local laws and regulations. Three, consider licensing yourself in other nearby states. When the pandemic was at its worst in March and April 2020, and shortly afterwards, they allowed for physicians to get very easily licensed in a number of states. And so many of you might actually even have other additional licenses. It may be valuable for you to keep those licenses, especially if you want to practice telemedicine, because that's something that you would be able to jump other areas. And then, this is really important, insurance policies can be expanded to have a particular telemedicine rider or a telemedicine section of that particular insurance quote. So it's important to go to your insurance company, especially if you're a private physician. What about informed consent and autonomy? When you're working at the hospital or you're working at your office, we have registration folks who will be able to come and get the consent for the patient for general care. But do you have that for your telemedicine practice? If you are using a third-party regulatory vendor, then probably the answer is going to be yes. But I'm certain that there are some exceptional entrepreneurs out there in the audience right now who may want to remove that middle person so that they can maximize their profits. And if that happens, you just have to make sure that you're doing everything to care for yourself. So one might think that if a patient, if they come in and they are asking or requesting telemedicine services, isn't that implied consent? That's voluntary implied consent, right? Although that's true, it needs to be stronger than that. So you need to have some sort of informed consent part of your interaction. Now, how are you going to make sure you ensure patient autonomy? Are you asking the patient the following question? Are you asking them if they're in a private or safe place where they can discuss their care? Are there others that are not in the camera? Are there others that are like outside of the region of the camera? And is somebody recording this particular experience? Now, you have to identify if you're going to record this as part of the medical record. The patient doesn't have to disclose that they are recording if they are. But what I typically will ask patients to do is I will ask them not to record, but if they really make it a point that they'd like to, then I just need to know that in advance. It's important to remember when you're talking about a person's decisional capacity, they need to understand what it is you're asking them, appreciate all of the different medical advice that you're giving, reason between the different pieces of advice that you give, and that they're free of coercion. And those four pieces are really important in this informed consent process. So my practical tip would be make sure that you have an informed consent process and make sure you're asking the necessary questions for patient autonomy. Next, let's talk about safety, privacy, and confidentiality. So studies have indicated that almost like 90% of healthcare organizations experienced a data breach in the last couple of years. And then in addition to that, almost 100% of web applications connected to critical information are vulnerable to cyber attacks. So if you think about the people and the technology, these are the moving parts of who you have that are part of your outfit. You know, healthcare employees, they use telecom equipment. Employees are responsible for moving, storing, and servicing all of the telecom equipment that they have. You may have IT personnel that are in-house who perform maintenance on the networks or the systems. And then you might have guests that might come into your office who are provided Wi-Fi access and are using the Wi-Fi that you may have generated. And so one of the practical tips that I would have about safety, privacy, and confidentiality is try to make sure that you get some version of cyber liability coverage, or that you have somebody specifically who is involved in as a data manager, as an information manager, or maybe even if you're part of a larger outfit, a chief information officer. They are the ones who are going to make sure that all of this information is accountable. With regards to technology, you know, you got to make sure that your people are trained. You got to make sure that there's maintenance. You got to make sure that you have some sort of security protection. Now, most people will use passwords. I don't know if you're using this type of system. It's a duo system here. I'll show you on my app. It's this system here. I don't know if that is going to show up well, but essentially what this does is it's a dual system that calls me back, and then I have to enter an additional piece of information. And if you use that duo system, it'll really make a difference in terms of protecting you against any of these types of attacks. With regards to data, I mean, this is really, really important. Having a custodian and manager of data is really crucial, like I mentioned on the last slides. Digital records, they take a lot of space. And if you record encounters, I mean, it can be terabytes of data. So you need to both protect that data and have a place to store it. So some of my practical tips here is have a data manager, like I mentioned before, information director, or a CIO, but find a secure outfit that you can store data. So I have this link here to the HIPAA journal looking at Cloud Security Alliance. It basically will give you an idea of where you can store information on the cloud. It has large spaces for folks who want to make sure that it's there and that it's secure. And how do you access that site? You can just find it by putting in, where do I store telehealth data securely? You can put that in your preferred web browser, or even look for it in this HIPAA journal. With regards to standard of care, this is probably one of the most difficult, but the most important aspects of what we do, right? In law, you're always held to the standard of what a reasonable physician would do in a similar circumstance. So in telehealth, we know that you have certain limitations by the virtue of the encounter. You know, we've talked before about, is the quality the same? I think the quality is really great. And I do believe that the quality on some levels can be better. Sometimes it's not as good. But in the court of law, I think the quality is still under question. And that's why I think it's really important that you know, we have a talk like this. So one, I would make sure that your scope of practice, you're practicing your brand of medicine. Two, you need to make sure that the patient understands the advice you're giving, and also this important piece, that they understand if they need to escalate. So make sure that, you know, you're explaining to them the signs and symptoms to look out for if they need to seek additional care, if the symptoms persist or if the symptoms get worse. You know, you're not going to have complete access to a set of vital signs, labs, diagnostics, consultants, or equipment. So, I mean, unless you have the wand, or unless you have some of these sort of extra toys, you may not have access to these different things. And so consequently, I would tell you that you have to make sure the patient knows that this is a telemedicine encounter and exactly what that entails. And then make sure you document and create a chart, and hopefully have a chance to combine it within the record. It's nice with the VA because they would have a combined record of shared information throughout. Obviously, if you're at a private outfit, you're going to want to make sure that you're combining it within your own record, or be able to combine it to a partner organization to make sure that the patient's record is secure. So in summary, you know, telehealth is the future. And I think it's really, really important that you learn the necessary skills for success. I think you should understand the local rules, regulations, and then take the necessary steps to protect your personal and professional interests. I think this is going to be a very fun and innovative way that we're going to take care of patients heading into the future. But I also want to just make sure that you're doing it accountably and responsibly. And with that, I thank you very much. I appreciate everybody's kind sentiments, and I'm happy to answer any questions that you might have.
Thank you, Manish. Again, it was great, and we are so privileged to have speakers like you and Veronica here today. And amazing talk. This is going to be telemedicine is here to stay, and medical legal aspects will crop up. There are too many lawyers in this country, and we know that we need to be aware of this. And thank you for the talk. Over to Ami for questions. Thank you.
Thank you, Dr. Garg. Absolutely wonderful, very informative, and well done presentation. So thank you. So there were some great questions in the chat. One of them, the first one was when we were talking about the numbers of how many telemedicine visits were being done, does that include just physicians, or does that include other providers such as nurse practitioners, medical assistants, nurses, et cetera?
That included everybody. I mean, but the numbers that I shared, I think were just the physician numbers that were there. However, within our outfits, we have physician assistants, nurse practitioners. So the whole gamut of folks are able to use it. And we know that everybody is using this platform. And I think that there are some pretty interesting questions there, because do these mid-level APPs have collaborating agreements with the physicians? Where exactly are those physicians? I mean, I think it's helpful from a profit standpoint and from running and maybe expanding a business, but from a regulatory standpoint, it does expose you to more risk. As an expert witness who helps to defend doctors, I've seen quite a number, and I've had to review a number of cases with where APPs have been sued, and then the physician is linked as part of that process. And so the one piece of advice I would give there is that in the clinical environment, we always say to have a linking phrase that says I was available for consultation, not a linking phrase that says I agree with the history, physical, exam, and have reviewed the entirety of this chart. If you have a linking phrase that says that, yes, you can get 20% more billing, but that puts you at risk for something much, much worse.
Right, that's really important. There's been a lot of questions throughout the day about regulatory agencies and billing, payment, reimbursements. How is it right now? There are concerns about private insurances not paying right now, like they were back in March of 2020. And what is the future of reimbursements from insurance companies?
So there's probably some awesome business folks on the call that can probably answer that question. I would probably defer to what Veronica was saying before, which is I think we need to show them the data. We need to show that this modality is critically important for patient care. And if they can see, specifically the insurance companies can see that it'll help prevent a really, really fat emergency medicine bill or an inpatient hospital bill. And if they look at it through that lens as maybe like a preventative care strategy, I think then it would be more likely to be supported. And I think some insurance companies are looking at it through that lens, but I think a lot of them are still just kind of looking at it as this isn't real medicine. You're not actually practicing medicine with a person face to face. So I think that area hasn't clearly been defined yet. And as we go forward, as we've gone from crisis of a crisis mode where we were just doing the pandemic to now a culture of telemedicine, I think we're going to start seeing that more and more.
Yeah, especially because over the course of the last year, we've seen so many clear benefits, right? We've seen, I mean, for us, we saw no-show rates significantly go down. We saw patients who actually wanted to come in to see their providers. So and the employees are engaged so much better, right? So there's definitely clear value that the regulators need to see. Another question that came up was, what is the role of wearable devices in telemedicine? So specifically, there was a question about pulse ox and in pulmonary usage, but in general, what is the prevalence of and the role of these wearable devices?
So I love this question. I think that it is really, really great. And I mean, one of the things that our outfit did, both at Cornell and Columbia, it didn't matter who you were or where you came from. If you came to the emergency department at the time and you were in that 90 to 95% range, we actually handed you a pulse ox and, get this, an oxygen cylinder. And we taught you how to use it. And then they studied all the folks that came back. And all of those people did not have bad outcomes, which was great. It was multiple hundred people that none of them ended up getting intubated or put in the ICU with their outcomes. I don't want to name names because I want to make sure that I'm not pushing forward a product because I don't have any proprietary interest in these products. But there are outfits that are out there that will check if you have AFib, right, through a watch. There are outfits out there that'll check your pulse oximetry. There are outfits out there that you can get an EKG rhythm strip. So all of that, I believe, is very helpful to us. And whenever patients present in the emergency department and have that data, I think it makes a huge difference because we're able to see it in real time and understand what's happening. I mean, functionally, it's like they're having like a Holter monitor or event recorder on while we're seeing the patient. So I think that that's a real plus side for where we're seeing technology go. And I'm hoping that that will be more and more. I mean, they're talking about devices that might be able to start performing ultrasound, which would be really, really amazing to have that for the patient at the site so that we'd be able to get real-time data that will help improve and promote patient healthcare.
Yeah, I think the role of technology is going to be pivotal in the expansion of telemedicine, right? So we're seeing already these devices, we're seeing AI being a part of this, we're seeing all this growth. So there's a lot to come, right? One of the questions that kind of relates to that was relating to cyber theft. So you brought that up, and the question was how diligently or how vigilantly do we think that security threat is being monitored and addressed right now?
So it's a full-time job. And, I mean, I got to tell you, I mean, I love this question. So one of the things that our chief information officer does periodically is sends us a fake phishing email that happens frequently. And I have to tell you, I mean, this is my area of interest and I have been caught by it once or twice in the past. And so being able to do that and having a culture of good telehygiene, I think is really, really critical. I received a phishing threat from my chair with the exact tag phrase, the exact everything on his email. The only difference was that the email said his name at Cornell at gmail.com. So it had 2 ats in there. Now, one of the things that if it comes on your email, it says external and it's very obvious. But if it comes on your phone, it's actually less obvious. And so it's really easy to respond back and say, oh, you needed this, And so like I mentioned before with the cyber theft, getting PHI is huge. And getting being a victim of ransomware also is, I mean, that essentially if that happens, if folks that don't know, you end up clicking on a link. And then what you've done by doing that is allowed this outfit to have access to your computer, at which case they will shut it down and then you'll have to pay a ransom in order to have it opened back up. And that can absolutely and completely destroy your outfit. And the way I look at it is it's probably something that if they really want to get you, they can get you. It's almost like a police officer just watching a bunch of cars flying by. If they just want to pick somebody, they can pick somebody, or a bear that's trying to look at salmon that are jumping upstream, it can just pick somebody. So having somebody whose dedicated role is the information director or the chief information officer, I think is critical.
Yeah, I think, a lot of large health systems are exposed to this often. And I know that that's something that they're constantly working on, but it's frightening, especially for the smaller practices, right? Where you don't have those big IT chairs kind of monitoring over your practice, right?
So, I mean, I think that would be my number one. Like, I know when people talk about, when they talk about, what are the things you need to set up a practice, your IT preservation to me is a number one issue.
Mm-hmm. Absolutely. That's good to keep in mind. So kind of staying on that track then, so we see a lot of in behavioral health, we see a lot of health disparities. But throughout medicine, there's a lot of health disparities. And one of the things we see is people having difficulty connecting, whether that's because of technical issues, because lack of bandwidth or whatever it might be, there's difficulty connecting digitally. And sometimes they're homebound, they need that service, right? Maybe this is a service that's essential for them. How do you address that challenge with patients? and providers for that matter.
Yeah, I think that part is, it's, they've looked at some of the data on what physical touch means for patients, particularly patients that are coming from vulnerable backgrounds, that if you physically touch a patient, you might be able to promote their health even 60 to 80% more, which is pretty incredible. And so I think part of the way that I try to address that when I'm trying to use a telehealth platform is I'm very intentional about what I say. So this is the time where I, like, when I'm talking to a patient, I would tell them, this is the time where I would be like welcoming you into my office. This is the time where I would put my hand, like on your shoulder as I'm listening to this and this and this. So I really want them to kind of like virtually feel like they're being cared for and loved, And I think that if we can bring some of that back, I think that will actually make the patient feel that level of connection that you're referring to, as best as we can make that connection. But I do agree with you that it can be very difficult, and particularly for elder patients or for patients who have maybe a psychiatric illness, or a patient who may be undomiciled. I think there are certain aspects that we need to really start looking at, and how can we improve some of these vulnerabilities. Just as like a funny thing, like the number of older patients with telemedicine that I see that are doing like they're doing this, and while they're talking to me, and I have to just keep coaxing them to get back into the center of the screen. I mean, it's really important.
Yes, absolutely. So I think because we have Sagar asking about, I think he has a little bit of like 15-20 minutes of talk time. So I think we'll wrap up with our questions here, and we'll let Sagar kind of step in now. Thank you so much for really an exceptional talk. You guys were just excellent today. Thank you so much.
Thanks a lot, Ami. It was awesome moderation, and Manish, as usual, you've always been a stellar speaker for us, and we enjoy your talks every time. Thank you for taking your time to do this. And last but not the least, let me introduce my friend Sagar Galwankar. He is been a long-time friend of mine. He's been in AAPI for such a long time. Recently, he has stepped out and pursuing this international goals of emergency medicine. He's a stalwart and a great resource in his field. And his accolades are many. He graduated from Pune University, and as a medical doctor, he's a board certified in internal medicine and emergency medicine, both in India and United States, and holds fellowships in Royal College of Physicians in UK, American College of Academic International Medicine, and Academic College of Emergency Experts in India. He additionally has Masters in Public Health and Masters in Business Administrator. So his MBA and an MPH also. His academic career, last 2 decades, is studied with remarkable achievements, from innovative strategies that led to the creations of organization, publications of landmark papers, combinations with prestigious citations and honors for his work that have impacted academic medicine and community globally. He has played a role in founding and building internationally recognized interdisciplinary index journals. He championed the establishment and growth of academic medicine in India, which is a benchmark of history of developing emergency medicine and world's largest and the most diverse democracy of the world being in India. He developed the emergency medicine there. He is the CEO of INDUSEM Health and Medicine Collaborative and heads World Academic Council of Emergency Medicine. He also serves as a global executive director for American College of Academic International Medicine and founding director of research in emergency medicine at Florida State University, and serves as a core faculty in FSU Emergency Medicine Residency Program at Sarasota Memorial Hospital in Florida. Wow, that was a mouthful, but what I can give you, in addition to all these things, he's a great innovator, and basically, and he is not mentioned, he recently got a very prestigious award for his work in emergency medicine by the Academy of Emergency Medicine in USA. And I forget the exact organization, and Sagar can do that. And he likes to remain in the background. He's like a diamond in the rough, I call him. But I dragged him out back into AAPI, and he's a part of my CME committee and is a person who gives amazing topics and speakers for CME. So without further ado, Sagar is going to actually do a wrap up of the telemedicine and involve certain other guests who may be on the call nationally and internationally. So over to you, Sagar.
Good afternoon, everybody, or good morning, everybody. Thank you, Amit, for that introduction. I would like Vijaya to please unmute Dr. Talor, who's logging in from Israel. I also have Dr. Salvatore logging in from Italy right now, and Dr. Prabhat from Amsterdam. These are one of the top experts in telemedicine today who are at the forefront of establishing fundamentals in our global network for big data monitoring when it comes to telehealth and telesecurities. We are going to discuss this topic. First, I want to commend the good work done by Veronica and Manish. It took us nearly 7 months to develop this framework. Telemedicine is not restricted to just having an audio-visual conversation, but the 4 pillars are very, very important. You can be sued using telemedicine data, so you need to know how to secure the data. You need to know what accountability is. When I talk about accountability, I'm talking about metrics, like there is door to needle time, there is a door to antibiotic time by CMS. There has to be some metric for analyzing telemedicine. Interesting topics like wearables were discussed. The most important part also is how do you store that data? How are we going to go back to that data and see whether quality of care was maintained? What is the expanse to which the clinical exam can go further to be able to interpret results and to prescribe medications or give advice? So these frameworks are very, very important. And as science in academic medicine evolves, telehealth or teleservices in academics will evolve as more and more academicians like me, Manish, and Veronica work hard to develop these frameworks as they become more and more complex. So it's just not a phone call, or it's just not a Zoom call. There's a lot more attached to that. And as academicians and scientists, we believe that proper frameworks are important if you want to evolve something. And that's where our total focus has been, whether it's the World Council, whether it's the American College. During COVID, we produced landmark papers. I have all my experts on. So what I'll do is, till then, Amit, can you please run the telemedicine etiquettes, a couple of slides? And Vijay, I would like you to unmute Dr. Talor. I sent you the message already. Dr. Talor, Dr. Prabhat, and Dr. Salvatore, who are on the call, so that we could have some discussion. Can we please do that?
Thank you, Sagar. And while you're getting them situated, again, I didn't want to present any slides, but I gave a talk for AAPI during Suresh Reddy's presidency time on etiquettes of telemedicine, which is, I won't put the slides, but there are certain etiquettes when you're doing telemedicine you need to be aware of, because though you're doing it from your home setting, number one, it has to be, the privacy has to be maintained. I mean, you have to go to your library and shut the door and actually work exactly as if you have to be HIPAA compliant, because you're at home, your wife or your kids can hear it, and so that's something which is not only medical legally required, but it's difficult to prove that. But for your own sake, you should actually have that etiquette of actually closing yourself in your study or library and conducting these talks. The second thing is that your background, the background which you have behind you, suppose you're doing it from your office and you have got patients' charts in the background with their names on it, you need to be aware of it, make the background blurry or do a generic background in the, but if you have some patient's data or charts in the background which the patient can see, they can take a screenshot and enlarge it and can see that. Also, be aware of all the books you have in the background. Some people may find it not very pleasant, something maybe politically or religiously sensitive data, to be sure that you have those removed from your background. Number three is time. Though you think that the patient is at home and he won't mind if I come a little bit late, no, they also have their time schedule. It's almost like an office appointment. You need to keep your time. You've got 15 minutes from 10 to 10:15. You better be there at 10 o'clock to be there. If you're running late, you have your secretary tell them that, hey, doc is running a little late. He'll be here at this particular time. It's very important for that to happen. Make sure, I don't have to tell you, make sure you can have a cup of coffee or something like that. Don't eat while you're talking. It's very easy to do because you're at home, and but that takes away from the professionalism of this thing. And lastly, but I mean, also you need to make sure your dog doesn't run and jump on your on you and stuff, because this is something which is important. But lastly, internet. Make sure your internet service is strong so that there is no disruption or no dropping of this. So that's a very short thing about telemedicine. Over etiquettes. Over to Sagar again. Thank you.
So these are very important points which Amit brought up. The key feature is to realize that telemedicine service, whether it's research, education, or patient care. So three core pillars of science in medicine is research, education, and patient care. Tele services are used at every one of these levels, and all these levels intermingle with each other. You can still do research on patient care. You can provide patient care to do research, monitoring systems, and education via teleservices. So all these things run complexly, and all these things have to be done. So without data, you wouldn't be able to implement something. Without data, you wouldn't be able to modify something. Without data, you would not be able to grow something. Hence, having a storage capacity for this data, having the video file stored, how are you going to make it accountable? How is the payment or the paymasters being able to pay you based on what you did in the tele? Are we going to put a form inside the telemedicine visit for clicks and clacks so that those points were met? These are very, very complex issues which will evolve with time when it comes to reimbursement. Right now, they just said you can do telemedicine, we'll pay you. It's going to change. It's going to become more and more stringent, more and more complex, more and more sophisticated. I would like to take some comments from Dr. Salvatore, who was at the forefront of implementing teleservices when COVID really surged in Italy. Dr. Salvatore, could you give me comments, please? And thank you for spending your time to be here.
Thank you, Sagar. First of all, let me congratulate with Manish and Veronica for the really very good speech summarizing the role of telemedicine in implementing worldwide approach after COVID in order to take care of patients at home. I just put in the chat 2 or 3 points that I think are relevant that we need to work together, making new papers and in the future to let people understanding how to proceed. Yes, as you said, now I am a part of the Italian government of developing of telemedicine in our country. It is becoming really a part of the renovations after COVID. So first thing, during the Manish speech, I was really thinking that it's time now to include new papers and the new guidelines, how telemedicine should be used in each disease. At the end of the day, I think that it's time now to create scores. What does it mean, scores? For each disease, during the call between nurses before that prepared to the doctor the speech and the telemedicine consultation or televisit, the doctor should be checked, but also with the with the support of nurses, scores of severity, so that these are going to be worldwide the unique questions that for each disease we are going to use, such as heart failure, COPD, COVID infection disease. And this is going to be integrating telemonitoring. At the end of the day, I think we should put all the activities of telemedicine like a virtual hospital. What we need is to put all these things that are starting during COVID as teleconsultation, like Manish very clearly showed, now in a continuous integration of 4 steps, making teleconsultation, then go for some patients that reach some score to telemonitoring. Then, if telemonitoring and teleconsultation need, we should send a team of professionals, nurses or doctors that are doing ultrasound at home and even point of care biomarkers to avoid patients coming in the emergency room. And if it's the case, the patient should be saved because we are intercepting a severe disease and we are bringing the patients to the hospital before it's going to, the situation is becoming more critical. And lastly, I would like to tell you that as an academics group, we should really worldwide increase the teaching process of telemedicine in nurses, in medical doctors, to make a kind of a discipline that so far has not been enough addressed. So again, congratulations for this opportunity that you are going to make worldwide. And this is time that we can lead, because we are really advanced of what we are doing to include. And then at the end of the day, telemedicine should be a way to select which patient to visit or not. And this is very important. So we have to put this final virtual hospital, including a lot of score and the consensus and the guidelines for each disease. I use telemedicine. Thank you again, Sagar, and all the people there that I really appreciate the way that you are doing, and we should cooperate together in the future in this topic.
Professor Salvatore, thank you very much. I know you're extremely busy. For all of you who don't know Salvatore, any publication you see in point of care trophon and BNP, NT-Pro BNP, he's a world leader in point of care technologies with Alan Marcel and Peacock and the 3 Trio, which brought the point of care testing to the medical world. One of the busiest persons in science, but I've been very blessed to be working with him for a decade. And thanks, Sal, for last minute request to join us. You've always been there with us and guiding us for high quality research. I'll go on to take some comments from another of my esteemed colleague, Dr. Prabhat Nayantara, who is a professor in the University of Amsterdam and also one of the foremost leaders of the famous fantasy trial on pre-hospital sepsis, which featured in Grey's Anatomy. A phenomenal singer, composer, as well as an acute medicine expert. He's one of my esteemed colleagues who has been working with me for years now. Prabhat, would you like to give a comments on the use of teletechnologies in the Amsterdam sector? Thank you.
Thank you, Sagar. Thanks for the invitation and also introduction. And Sal, good to hear from you, and Manish and Veronica for the talks. I do lots of research on implementing algorithms to decision support also during telemedicine. We are not very scared of individual litigations here in the Netherlands because most of the patients are cool with that. And our acute care system, when you compare it to how busy that is, we see about 1/5 of patients you see in US or UK when corrected for the population. So we use telemedicine mostly for subacute care. And I also do outpatient clinics where after the pandemic, I see about 60% of the consultations are telemedicine, video consultations and audio consultations. And I work in a hospital with 18,000 people and we have all these officers, telemedical officers, but still we had cyber attacks, asking for ransomware or asking for Bitcoins and all that. So that's going to be a problem in the future. But individually, we have been using telemedicine during the pandemic also, not only to see the patients with COVID, but especially to the patients without COVID. And when it comes to wearables, I think the problem with wearables is going to be how can we get relevant data? Because you're getting lots and lots and lots of data. If it's irrelevant, there's going to be an alarm fatigue. And I think that's going to be a challenge for the future. And we are working on it also. And I really like what Manish said, you know, the Voltaire, who is a philosopher, he said, art of medicine consists of amusing the patient while nature cures the disease. The touching the patient can be very important. And we are going to miss that. But anyway, showing the patient your empathy can be of help. So those are the techniques which we should train young doctors when they do telemedicine. And I think there's lots of potential for telemedicine and hope to work with you to make it a success in the coming years. Thank you.
Thank you, Prabhat. Thank you for the phenomenal comments. You've always, I hope the decision algorithms which we are working on can help us in the telemedicine sector with our artificial intelligence systems, which we are building. Last but not the least, one of our other strong colleagues and I think one of the people who implements things before the world sees it is our colleagues in Israel. And I would request Dr. Talor, it's my second home. I go there all the time. Dr. Talor to give his comments on telemedicine and what a fantastic operations they are running in Israel as they control the multiple surges of the pandemic and reach out to their patient with the philosophy that no patient left behind. Dr. Talor, please.
Good evening. In Israel, it's almost 8 o'clock in the night, so good evening here. Thank you for letting me join this meeting. I like it very much. Good to see Manish after so long. And it was very good talk, both of them. I liked it very much and enjoy it. In Israel, we started telemedicine in 2 phases. The first phase was from the HMO, which means we don't have a problem of payment because the HMO is the insurance parties that take care of the patient. And if they are doing the telemedicine, they pay for themselves. And so we don't have a problem with that. We start with the children. The first telemedicine was done by the pediatrics with a title. They can hear the lungs, they can see the ear, and so on and so forth. And this was the start, and it worked very well. So they go to the adult and do for a physician for them HMO instead of going to the patient. And of course, the coronavirus empathize it, and it's make much and more common. And now in the EMS system, we have what we call hybrid system. We have a paramedics that go with the ambulance, with the equipment to the patient. They connect to the physician who stay in the headquarters of Magen David Adom. They have a lot of point of care testing like blood tests. They have titles. They can hear the ECG. They can do even now we try to do ultrasound that we can transmit it to the physician. And then the problem was it was coming because in Israel, if you call ambulance, usually you get to the hospital. And in the time of the coronavirus, most of the patients didn't want to go to the hospital. So we have to find a resolution how to check them and decide whether or not they can stay at home. So we built this system when the paramedics go to the patient, they check him, they show it to the physician in the headquarters and decide whether or not this patient should go to the hospital or can stay at home. And what Salvador said about in Italy or in Amsterdam, that they want to be first to know whether or not the patient has to go to the hospital, we did it in the EMS system. It's very wonderful, and we're going to elaborate it and make it more, sorry?
No, you can continue.
Okay, and its world will be wider and wider in the time, and it's do 2 things. Once it takes the patient in their home very soon. We don't have, and second, it's take some of the load of the emergency department, because if you check the patient, you do a blood test and so on, and you understand it doesn't have to go to the emergency department. It takes a little bit of the load from the emergency department in Israel. I think for the future, we have to, you talk about a lot of data that we have to store and to use. I think now we have less data, a small frame of data, because now we're talking about wearable telemedicine. People will wear some gadget on their body and it will send. We want to know if he's going to do a sepsis or he's going to have a fall, and we are working already on it. And just think how much data you're going to get for thousands of people that wearing this wearable, or 10,000 of people wearing this wearable device, sending their data all the time, 24 hours a day. And so I think there's where the world is going to, and I think that it will be a really game changer, all the telemedicine.
Thank you, Dr. Taylor. So to summarize all our three experts, Dr. Salvatore spoke about the various levels at which you go from consultation to telemonitoring systems, to Dr. Prabhat talking about machine learning and about artificial intelligence and algorithm-based approaches and decision-making tools, to Dr. Taylor talking about the advanced technologies of wearable and the concise accumulation of data to interpret smart decisions in smart places. So I call this era as a digital adjustment era, and we have made a leapfrog in COVID where we had to digitally adjust into spaces. Many corporations went to working from home as the new model. Doctors had to adjust to telemedicine, had to go into Zoom meetings. Of course, that was one of the greatest. Students had to learn digitally. Children had to go through digital schools. So we went into digital places, and now is the time to evolve these digital places and digital spaces for the future. And I think it's more economical, but also more challenging because you're generating that kind of data, which is always at a risk of being invaded and misused. So security takes a major toll. But again, this whole new framework is a complete environment or an ecosystem we are trying to create in our new world. And the youngsters, the generations which are going to come to it, which includes our children and us, for matter of fact, have to adjust to that. I would encourage everyone to visit these countries whenever they can and see all these fantastic scientific locations where we work at, including Israel, Amsterdam, Italy, where the scientists work and what hard work goes into concising this kind of data. I'm very proud of Manish and Veronica. Veronica was our student when she joined the INDUSIM mission to India in 2009, and she was evolved to be one of our most phenomenal leaders, and we are very proud of her. And of course, Manish came to us in 2015 as a visiting professor and became one of us over the years and has evolved himself to be a global leader. So I'm always proud of my colleagues who have joined it and my friends across the world who support my mission for innovative patient-centered education, research, and care, which is so very important because when you go together, you grow together. And that's the key, as the future of medicine lies in big data, lies in point of care testing. And what I see, to summarize this whole thing, is self-care before healthcare. And that's the tagline which I would like to end on. I thank Amit Chakravarti specifically for talking to me and engaging with me and getting me to design this phenomenal symposium for you all. I hope you all liked it. I hope you all can take some messages home, and I hope for the best that telemedicine will evolve. So self-help, self-care before healthcare. And thank you very much.
Great, Sagar. You are a star. Thank you so much for bringing such a stellar program. This, everyone has appreciated. As you can see, the chat box kind of blazing away. And I knew that you would step up to the plate, and we've got several more coming up. I would like to indulge the audience for another 5 minutes or less. I'll have Anupama give the vote of thanks. And I have got very exciting news on the upcoming things coming up for the telemedicine. In fact, I would like your input on those things. So please hang around for another 5 minutes. I'll come back after Anupama gives her vote of thanks. Thank you.
Thank you. Thank you, Amit, and thank you all the speakers today, Dr. Manish and Veronica, and our moderators, Stella and Amit Bakshi and Sagar. Amazing talks. And, doctors, patients, and, it's a transition of medicine to telemedicine mostly due to the pandemic. I think every pandemic gives some kind of a revolution. So I think telemedicine is the current one now. And according to one study and a McKinsey report, it says that telemedicine accounted for 32% of office and outpatient visits and have stabilized at 13 to 17% across all specialties. And the largest insurance carrier, United Health Group, they covered 1.2 million in 2019 versus 34 millions in 2020. That's the way the telemedicine is right now. And telemedicine is here to stay forever. I think this is a revolution now. And Vijaya, can you open up Dr. Veronica's This is a small gratitude from AAPI to our speakers today. And thank you, Dr. Manish Garg, for your outstanding contributions to emergency medicine. And we welcome you as member of AAPI Distinguished Speakers Club. And this is from myself, Anupama, President of AAPI, and our CME Chair, Dr. Amit Chakravarti. And thank you so much. And Veronica, thank you so much and for your outstanding contributions today to emergency medicine and telemedicine at the VA. And we welcome you as a member of AAPI Distinguished Speakers Club, presented to you by AAPI President today, Anupama, and Amit Chakravarti from CME Committee. And thank you all so much. And thank you, our distinguished members, and listening so long. And we are very appreciative of your time on a Saturday. And this is an honor for us. And we are humbled that we want to do more and more for AAPI members, deliver best CME talks for all of you every month, second Saturday. And Amit, please, to you again.
Thank you so much, Anupama. And I'm so excited that we've got very, very nice quality audience on a Saturday morning. And obviously our speakers excel every time. And we just go from pillar to post, so to speak. And we are getting better and better every time. And I'm thrilled to announce that we've got some more things coming up. Our talk is usually on second Saturday of each month. Usually it's between 12 to 2 Central Time. This time we had to move because of speakers' obligations, but otherwise we'd like to stick to 12 to 2 Central Time, second Saturday of each month, so that you can put that on your reminder calendar and then you can be there. So we've got a few things which are in the works. One, we are trying to bring heartfulness and meditation on stress in the time of pandemic and how to preventive strategy to improve community health in healthcare professional and patients. So this is one we are toying with. The other idea which we're thinking of developing is concentrating on hospice care, because that's something which everybody in every specialty has to deal with. And what are the implications? What are the ins and outs? What are the things you need to know about hospice care? And the third thing which we are trying to think of is polypharmacy. Polypharmacy has a problem, is an issue which all of us face, but we don't know much about, and how prevalent it is, what are the implications, both medico-legally and from the patient wellness standpoint. So if you have a couple of minutes, just put a couple of your comments on the chat box. What do you think about these 3 topics we are working on? And we'll let you know well in advance, and see you second Saturday of December. Thanks so much, and appreciate all the moderators, Stella, Amy, and of course, Sagar and Anupama, and for giving us this opportunity for doing so. One more thing which Anupama wanted to ask you to do is that Global Health Summit, which is coming up in Hyderabad. I would like all of you to come and join us. We might actually try to include a telemedicine, teleconsultation, and technology forum or a workshop in that session in Global Summit. So on behalf of Anupama and the whole executive committee, I'd like to welcome you to Hyderabad, January 5th to 8th, 2021.
Thank you, Amit, and hope to see many of you in Hyderabad, January 5th to 7th at Global Health Summit. This is after a long time post-pandemic. I think we are, rejuvenating again, and it's a refreshing one again for us to join in India. So we haven't been to India for almost 2 years. So I think this is a good opportunity for us to travel to India, attend the summit, and enjoy the family. Thank you.
Great. Thank you. Thank you. And I've got chat boxes saying they're wonderful. Bring them all on. So all 3 of them are very interesting for everyone. Thank you very much.